Hello, students, and welcome to Chapter 21, Kidney Disease. So, there are more than 120,000 Americans diagnosed with end-stage renal disease annually. There are many more with compromised kidney function who remain undiagnosed and untreated, and this is very sad to know, especially in those communities that they don't have access to good healthcare insurance, right? The National Health and Nutrition Examination Survey found that less than 15% of individuals with chronic kidney disease stage 3 and 4 are aware of their condition, because kidney disease, they have different stages, and the end stage is the last one, and usually patients are on dialysis at that stage. Kidney disease are costly to both the individual and society because they result in a loss of productivity, income, leisure time, and overall quality of life. And that's good to know. Okay, the statistics and the overall knowledge about the stages in kidney disease. Basic structure and function of the kidney. We are going to watch a video that is it's a 2-3 minutes video, I think. Okay, and we are going to have a better comprehension about the condition. Let's watch this video.
It's a hot day, and you've just downed several glasses of water, one after the other. Behind the sudden urge that follows are two bean-shaped organs that work as fine-tuned internal sensors. They balance the amount of fluid in your body, detect waste in your blood, and know when to release the vitamins, minerals, and hormones you need to stay alive. Say hello to your kidneys. The main role of these organs is to dispose of waste products and to turn them into urine. The body's 8 liters of blood pass through the kidneys between 20 and 25 times each day, meaning that together, these organs filter about 180 liters every 24 hours. The ingredients in your blood are constantly changing as you ingest food and drink, which explains why the kidneys need to be on permanent duty. Blood enters each kidney through arteries that branch and branch until they form tiny vessels that entwine with special internal modules called nephrons. In each kidney, 1 million of these nephrons form a powerful array of filters and sensors that carefully sift through the blood. This is where we see just how refined and accurate this internal sensing system is. To filter the blood, each nephron uses 2 powerful pieces of equipment, a blob-like structure called a glomerulus, and a long stringy straw-like tubule. The glomerulus works like a sieve, allowing only certain ingredients, such as vitamins and minerals, to pass into the tubule. Then, this vessel's job is to detect whether any of those ingredients are needed in the body. If so, they're reabsorbed in amounts that the body needs so they can circulate in the blood again. But the blood doesn't only carry useful ingredients. It contains waste products too, and the nephrons have to figure out what to do with them. The tubules sense compounds the body doesn't need, like urea, left over from the breakdown of proteins, and redirects them as urine, out of the kidneys and through 2 long sewers called ureters. These tubes empty their contents into the bladder to be discharged, ridding your body of that waste once and for all. There's water in that urine too. If the kidney detects too much of it in your blood, for instance, when you've chugged several glasses at once, it sends the extra liquid to the bladder to be removed. On the other hand, low water levels in the blood prompt the kidney to release some back into the bloodstream, meaning that less water makes it into the urine. This is why urine appears yellower when you're less hydrated. By controlling water, your kidneys stabilize the body's fluid levels. But this fine balancing act isn't the kidney's only skill. These organs have the power to activate vitamin D to secrete a hormone called renin that raises blood pressure, and another hormone called erythropoietin, which increases red blood cell production. Without the kidneys, our bodily fluids would spiral out of control. Every time we ate, our blood would receive another load of unsifted ingredients. Soon, the buildup of waste would overload our systems and we'd expire. So each kidney not only keeps things running smoothly, it also keeps us alive. Lucky, then, that we have 2 of these magical beans.
Beautiful. I love it. This was a great video. So in a few minutes, we are able to review the full kidney function. So now we are going to skip this part. Okay, and let's remember this. This is the current method of monitoring kidney function and for defined stages of kidney disease. They are talking about the glomerular filtration, the GFR, that is on your CMP, your comprehensive metabolic panel, right? So the current standards of care define chronic kidney disease as a GFR of less than 60, which is adjusted to a standard body surface, or 3 or more months, right? So GFR less than 60 for 3 or more months, or a urinary albumin to creatinine ratio. Remember, the creatinine is the factor that is crucial in monitor your kidney status, right? Albumin to creatinine ratio of more than 30, and that's good to know. Okay, so we have a couple of definitions that probably you want to go over: dialysis, nephron, glomerulus, Bowman capsules, and glomerular filtration rate, GFR. So here you have a couple of images that are basically summarizing whatever we saw on the video. We have on the top part on the left, we have the renal artery, the renal vein, the urethra. You can see the nephrons, these kind of islands inside of the kidney, and then these islands are going to be expanded so we can see inside of the nephron, right? We have the proximal tubule, the glomerulus inside this network, right? Distal tubules, the urethra, okay? And then here we can see another structure from another point of view. Okay, the Bowman's capsule, which is important, is the one that is holding the glomerulus, right? Okay, so the tubular components, you have a very nice description here. And then let's switch to function. Nephron structure is adapted in fine detail. Okay, we know the nephron, the small islands, right? Is adapted in a fine detail to balance the internal fluids that are necessary for life. At birth, most people have far more nephrons than needed. That's when we are born, right? Many nephrons. But the number decreases with advancing age. Chronic hyperglycemia and hypertension exacerbate damage to the glomerulus and increase the rate of loss functioning nephrons. So those two are very important to remember. So when we talk about the conditions that are going to decrease the number of glomerules, don't forget it's chronic hyperglycemia and hypertension, and that's good to know. And I would say this is an NCLEX alert. Excretory and regulatory functions, right? The kidneys perform, okay, that's good to know. Don't forget that. Okay, not only for the exam, but for everything else. Excretory and regulatory functions. The kidneys perform the following excretory and regulatory. Excretory means getting rid of, and regulatory tasks while blood flows through the nephrons. Okay, so one is filtration. The kidneys filter most particles in blood except for the larger components of red blood cells and proteins. So it's going to remove most particles in blood. And then reabsorption. The winding tubules selectively reabsorb and return to the blood substances within the filtrate that the body needs. So the kidney, the nephrons, they are going to say, I think we still need these particular substances. So let's return this to the body. This process helps maintain the electrolyte, acid, base, and fluid balance. So when we are mentioning electrolytes, we have to think about sodium and potassium, right? Also, the third one is secretion. Along the tubule, secretion of additional hydrogen ions occurs as needed to maintain the acid-base balance, okay? Secretion, filtration, reabsorption, and secretion. Filtration is, I need this, okay, we don't need specific components, so let's get rid of them. Reabsorption, we need these components, and secretion is going to refer to the hydrogen ions. So in table 21.1, we have the reabsorption and secretion in parts of the nephron. This is a very interesting table. For example, we have the proximal tubule. The function is reabsorption, active and passive. And basically you see the number of electrolytes, right? The sodium, the chloride, right? And other particles like glucose, amino acids, urea, water. In the loop of Henle, we are going to basically see the reabsorption and secretion phases. Water, urea, sodium, chloride are taking place here. So probably you can make a flashcard. Loop of Henle, reabsorption, secretion, water, urea, okay? Distal tubule is going to work on the reabsorption and the secretion. And we see here how the sodium, chloride, some electrolytes, ammonia, that's the difference between the other ones, right? And in particular, the distal tubule is going to have the participation of the antidiuretic hormone, which is very important to remember, okay? This is crucial. And this is another differential, the ammonia. The collecting tube, reabsorption and secretion, right? Sodium, urea, ammonia. So in these two, the distal tube and the collecting tube, we can see the presence of the antidiuretic hormone and also the ammonia, okay? So that's important. That's very important, I would say. I'm going to select this one. Okay. So excretion is the now concentrated urine contains waste minerals ready for excretion. So we have filtration, reabsorption, right? Filtration, reabsorption, secretion, and excretion. Okay, so those are the kidneys, the excretory and regulatory task while blood flows through the nephron. Okay. Now, endocrine functions of the kidneys is very important. The endocrine system is composed of glands that secrete hormones directly into the circulatory system, right? Many of these hormones have a response within the kidney as follows. One, the renin secretion. When the arterial pressures fall, the kidneys activate and secrete renin, which is an enzyme that initiates the renin-angiotensin-aldosterone mechanism to reabsorb sodium and to maintain hormonal control of the body water balance. So now we have the renin secretion, and this is the renin-angiotensin is the one that is going to be present in the blood pressure, right? Balance. Now we have the erythropoietin secretion. The kidneys are responsible for producing the body major supplying 80 to 90% of erythropoietin. And then we have vitamin D. The kidneys convert an intermediate inactive form of vitamin D into the final active vitamin D hormone in the proximal tubules of the nephron. Okay, the parathyroid hormone stimulates this action. I'm going to repeat this because vitamin D is extremely important, not only for the kidney functions, but also is important for immunity and to prevention of chronic diseases. So vitamin D activation, the kidneys convert an intermediate inactive form of vitamin D. So that inactive form is because remember, the body does not produce vitamin D. We either get it through the sun, right? Or the sun in contact with the skin, right? Or by supplements. So that is the inactive form of vitamin D into the final active vitamin D hormone in the proximal tubules. That is where the magic occurs of the nephrons. Okay, so it's going to be converted in the proximal tubules from the inactive form, which is the supplement you take, into the active form. The parathyroid form stimulates this action. So if you have a patient that is having parathyroid issues, the vitamin D is not going to be converted into the active form. Okay, and this patient is going to probably, out of the, let's say the patient is taking 10,000 units of vitamin D per day, because the parathyroid is not working properly, probably the conversion is going to be only for 5,000 units, not the 10,000 units. Okay, disease process and kidney considerations, general causes of kidney disease, and that's good to know. Let's review this. Several disease conditions may interfere with the normal functioning of nephrons and eventually result in kidney disease. So we have infections, other causes of obstruction such as prostatic hypertrophy, right? Which blocks urinary tract drainage, may lead to general tissue damage and kidney disease. Okay, and remember, we have the kidneys and then we have the ureters that are going to the bladder, and below the bladder is the prostate. So if we have other causes of obstruction such as prostatic hypertrophy, means that we have a prostate that grows in an abnormal way, that blocks urinary tract drainage, right? And may lead to general tissue damage and kidney disease. Just visualize how the prostate that is very large, that is large in size, right, is going to blockage the urinary drainage, right? So you have to visualize. That's why always I tell you to know your map. Various environmental agents like animal venom, certain plants, heavy metals, and some drugs like non-steroidal anti-inflammatory drugs, aminoglycoside antibiotics, and radiographic contrast dye, right? The dyes that they use for your CT scan, MRI, I don't know, are nephrotoxics and can cause kidney damage. That's why when you go for MRI, the first thing probably is if it's going to be with contrast, right? Or a CT scan with contrast, they are asking you, we need your last blood work. We need to see your kidney function, okay? Damage from other diseases. And also, I would recommend, right? Let's say your kidney function is good in the blood work, in the report, but in order to get rid of that radiographic contrast, you need to drink a high volume of fluids. So also you have to double check how is your heart, right? If you're having a kidney function that is just borderline and it's good, and you have to check with your cardiologist. Do you suggest me to do this type of test? How much fluid am I supposed to tolerate? This and that, okay? Damage from other diseases. Well, and this is an NCLEX alert. That's good to know, to check your kidney functions in order to prevent nephrotoxicity. Damage from other diseases. Diabetes mellitus is the leading reported cause of end-stage renal disease in the United States, right? Remember, we already reviewed hypertension and hyperglycemia in chronic stages, right, are going to diminish the amount of nephrons that are going to be functioning in the kidneys. So again, hyperglycemia and hypertension associated with diabetes causes damage to the small renal arteries, thereby leading to glomerulosclerosis, right? The loss of functioning nephrons and eventual chronic kidney disease, CKD, chronic kidney disease. Other chief causes are glomerulonephritis, right? Inflammation of the glomerulus, And cystic kidney disease. Any cyst can cause this type of conditions. Autoimmune diseases such as systemic lupus erythematosus, that we are going to learn with B in the fourth semester, may also lead to compromised kidney function or disease. Okay, so be familiarized with these conditions. Excuse me. Genetic or congenital defects. So cystic disease, you have polycystic kidney disease, medullary cystic disease, are genetically linked kidneys. Okay, here a couple of terms: arterial erythropoietin and nephrotoxic drugs are explained. And also, what else is saying here? So the genetic or congenital defects, they are related to polycystic kidney disease medullary and genetically linked kidney diseases that may lead to end-stage renal disease later in life. Risk factors for these conditions: risk for chronic kidney disease, CKD, from now on, are higher among individuals who have diabetes, okay, hypertension, or cardiovascular disease, are older than 60 years, patients that are obese, and have a family history of kidney disease. So risk for chronic kidney disease, again, we have diabetes, hypertension, obesity, family history, right? Or the age, older than 60. And that's good to know. Please don't forget these factors. Okay, that's good to know. Because at the end, when you come for evaluation or when you are going to assess a patient, right? A walking patient, or maybe an emergency room, the patient is walking, you need to know these facts in order to do a proper assessment, what you are looking for, right? You have this patient complaining of this, and this. What are you going to look for specifically? That's why these factors are important. Malnutrition can intensify the rate of renal disease destruction and increase susceptibility to infection, right? So the prevalence of CKD is higher in racial and ethnic minority populations and among individuals with low socioeconomic status because they are not eating a right amount of protein, right? And the electrolytes are going to suffer as well. So malnutrition is a risk factor. And also people that are in racial and ethnic minority populations with low socioeconomic. This increased prevalence is due in part to modifiable contributing factors such as smoking, alcohol intake, and limited access to health care. But keep an eye. Sometimes, and I would say in many occasions, you can find patient with malnutrition is not eating the protein, fruits or vegetables, but they do have money for smoking, alcohol, blah blah blah. So we are going to check that box 21.1 summarizes the risk factors and common causes of kidney disease, and then we go back to medical nutrition. Okay, so we have socio-demographic factors: the age, family history of kidney disease, hereditary diseases like polycystic kidney disease, clinical factors: the chronic hyperglycemia, hypertension, obesity, autoimmune, glomerulonephritis, systemic infection, right? Repetitive urinary tract infections or kidney stones, lower UTI, history of acute kidney injury, reduction in kidney mass or congenital malformations, exposure to certain nephrotoxic drugs or environmental conditions. So these are the risk factors. Let's go back to the medical nutrition therapy and kidney disease. During the treatment of this condition, the dietitian will determine the appropriate medical nutrition therapy based on the severity of the disease, right? And also the presence of metabolic abnormalities. Let's say if the patient is having diabetes, distended abdomen, hypertriglyceridemia, right? Blood pressure, high blood pressure, and the treatment modality in use, renal replacement therapy medications. So length of the disease, also drug therapy with antibiotics usually control short-term acute disease resulting from bacterial infection. Yes, the goal of nutrition therapy is to provide optimal nutrition support for healing and normal growth. We already reviewed this table. Let's go to degree of impaired kidney function and clinical symptoms. So when there are only a few nephrons involved in a case of mild acute kidney disease, there is less interference for overall kidney functions, right? Because there are so many nephrons in the kidneys, I remember it's kind of 1 million glomerulus per nephron, right? So there are so many nephrons in the kidney that unaffected nephrons can usually meet basic needs. However, in case of progressive chronic disease, more and more nephrons become involved, which eventually results in CKD. Such cases require extensive medical nutritional therapy to help maintain kidney function as long as possible. Intentional nutrient modification help to meet individual needs and address clinical symptoms as the disease progresses. So working closely with a dietitian that is board certified as a specialist in renal nutrition for personalized MNT is especially important for those with advanced kidney disease. So now we are going to stop here. When we come back, we are going to speak about the nephron diseases, acute glomerulonephritis, nephrotic syndrome, okay? And we are going to go through all these conditions, including kidney failure and what else are we going to do? Chronic kidney disease, okay? So let's stop here and we will come back soon.